Venous ulcers. Venous leg ulcers occur as a result of venous insufficiency and thought to affect around 1 to 2% of the adult population. Venous leg ulcers are accountable for around 70 to 90% of all leg ulcerations. Let's start with the anatomy. The venous system is a low pressure system that returns blood to the heart. Valves in the veins of the extremities prevent retrograde flow, and with the help of the skeletal muscles that surround and intermittently compress the leg veins in a milking manner, blood is moved forward to the heart. The pumping action is known as the muscle pump. The venous system in the legs consists of two compartments, the superficial veins and deep venous channels. Perforating or communicating veins connect these two systems. Varicose veins of the lower extremities are common and often lead to secondary problems of venous insufficiency. The final common pathway that leads to chronic venous insufficiency is the development of venous hypertension. In most cases, venous hypertension results from the venous valves dysfunction, obstruction to the venous flow, or failure of the venous pump. Suppose the valves of the deep or perforated veins are incompetent. In that case, the increased pressure generated during the standing or calf muscle contraction causes blood flow to reflux into the superficial venous system, converting it into a high pressure system. Chronic venous insufficiency is characterized by signs and symptoms associated with impaired blood flow. In contrast to ischemia caused by arterial insufficiency, venous insufficiency leads to tissue congestion, edema, and eventual impairment of tissue nutrition. In advanced venous insufficiency, impaired tissue nutrition can cause stasis dermatitis and the development of venous ulcers. Stasis dermatitis is characterized by thin, shiny, bluish-brown, irregularly pigmented, desquamative skin that lacks the support of underlying subcutaneous tissue. Brawny pigmentation of the skin is caused by hemosiderin deposits that result from the breakdown of red blood cells. Minor injury leads to relatively painless ulcerations that are difficult to heal. Most lesions are located medially over the ankle and lower leg. Skin changes related to chronic venous insufficiency, including edema, hyperpigmentation, fibrosis, atrophy, and ulceration, are reported slightly more in women than men. Established risk factors for varicose veins and chronic venous insufficiency include age, family history of venous disease, female sex, standing occupation, obesity, history of deep venous thrombosis. Actually, 50% of venous leg ulcers occur as a result of recanalization of DVT, called as post-phlebitic leg. Other causes are smoking, sedentary lifestyle, lower extremity trauma, heart failure, and hypertension are aggravating factors. Characteristics of venous stasis ulcers include location between the knee and the ankle. The medial and lateral malleoli are the most common sites. Pain is not usually severe, usually dull and aching, relieved by compression and elevation. If pain is severe, it suggests invasive infection or concomitant arterial insufficiency. In the image, you see inverted champagne bottle sign, which is seen in lipodermatosclerosis due to prominent calf with narrow ankle, tight contracted woody leg skin, and subcutaneous tissue, which is more fibrotic and less elastic, often with Achilles tendon contracture. This sign is often observed in DVT as well. Lipodermatosclerosis is hyperpigmentation accompanying erythema, induration, and plaque-like structural changes. These contribute to intense pruritus in the region. The condition is often associated with slower wound healing rates. Variable wound bed appearance. The wound is frequently beefy red with granulation tissue, superficial, irregular in shape, edema stops or delays epithelialization. The treatment of venous ulcer depends on several factors: losing weight, active and passive exercise to contract calf muscles, correct way of walking with the heel down first, once weekly application of moisturizer on intact skin and massaging it, rest with leg elevated above heart level, debridements, antibiotics for wound infection, suitable primary dressing with multi-compression dressings, ABI Doppler to rule out concomitant arterial ischemia, and venous duplex ultrasound to rule out DVT. Ulcer debridement is an essential component of the management of venous ulcers. The presence of devitalized tissue increases the potential for local bacterial infection, reduced wound healing rates, and reduces the effectiveness of topical therapies. Different bandages used are elastic multi-compression dressing, low compression dressing, graduated elastic compression stockings, Unaboot, and crepe bandage. As long as multi-compression dressing is used, the class of primary dressing does not affect wound outcome. Compression therapy reduces venous wall tension, diverts the blood towards deep veins, prevents reflux, improves calf muscle pump, reduces edema, thereby improves the ulcer healing rate in venous ulcer. And in post-phlebitic leg, it's recommended to have 40 to 45 millimeter mercury is the recommended pressure. In phlebolymphedema, much more difficult to treat, requires more than 45 millimeter compression pressure. And also negative pressure wound therapy enhances the healing of chronic venous insufficiency ulcers. Lastly, the complications of venous ulcers are bleeding, infection, disability, calcification, periostitis of tibia, Talipes equinovarus, also called as clubfoot, and Marjolins ulcer, which is seen in the image, is an aggressive ulcerating squamous cell carcinoma seen in long-standing chronically inflamed venous ulcer. To rule it out, wedge biopsy is required from the edge of venous ulcers. Lastly, healing of an ulcer does not occur with compression therapy alone. Therefore, it is important to educate the patient about venous disease, the role of compression therapy in treatment and prevention, and health advice in regard to leg elevation, foot exercises, nutrition, sleep, hygiene, and pain management. Thank you.